Welcome to Have More Babies. Today, we're getting into something important, really crucial actually, based on some source material about a common, but maybe not always understood, issue in kids' health. We're talking about inguinal hernias in children. Our goal here is pretty simple. Cut through the noise, give you, especially if you're a parent of a baby or toddler, the clear facts. What is it? Why does it happen? And, what's done about it? Think of this as your quick guide if you're feeling a bit lost in all the health info out there. So the source material calls it the unseen culprit. Let's start right there. What exactly is an inguinal hernia, structurally speaking?
Yeah, that's a good phrase because it often shows up when kids are too little to say what's wrong. Basically, an inguinal hernia is when some tissue, usually a bit of the intestine, pokes through a weak spot in the muscles of the abdomen. And it happens in a specific place, the inguinal canal, which is down in the groin area. Mostly we're looking at something congenital, meaning the child's born with the potential for it. And while it's not usually, immediately life-threatening, it definitely needs medical attention because things can get serious if it's left alone.
Okay, congenital. So it's about that structural weakness you mentioned,
Yeah.
not just a random tear, right? It links back to how babies develop before birth.
Absolutely. It's often about something called the processus vaginalis. During development, there's a passage, the inguinal canal. In boys, the testicles travel down through it. In girls, a ligament runs through it. Normally, after that happens, this passage is supposed to close up completely, but sometimes, especially with what's called an indirect inguinal hernia, the most common type in kids that tube at the processus vaginalis, just doesn't seal all the way. It leaves an open sac. Then, if there's pressure inside the abdomen, it can push the intestine into that open sac. That's your hernia. So factor one is that failure to close, congenital weakness.
Okay, that makes sense. It's like a step in the process wasn't quite finished. So if that weakness is there from the start, what else makes a hernia more likely to actually appear? What are the triggers?
Well, the clinical information points to a couple of key things. Second, and this is a big one, it's much more common in babies born prematurely. A preemie's muscles haven't had as long to develop, so that processus vaginalis is just, statistically more likely not to have closed properly yet. They miss those final weeks of development time.
Okay, prematurity is a major risk factor. And the third?
The third one is increased abdominal pressure. This is where things parents might notice come into play. Anything that makes a child strain a lot. Like, think about chronic, really forceful coughing from a bad respiratory illness, or even constant intense crying, maybe from colic or something else causing pain. That pressure can push tissue through an opening that's already there.
Right, which brings us to the really practical part for parents listening. What are the signs? Since babies can't tell you what's wrong, what should you actually look for?
Yeah, this is key. The number one sign, the most common thing, is a visible lump or swelling right in the groin area or the lower belly. It might not be there all the time. That's important. It often pops out when the baby cries, coughs, or strains, during a bowel movement. And then it might disappear when they relax or sleep.
And for boys specifically?
For boys, yeah, you might see that swelling go down into the scrotum. So one side might look bigger or puffier than the other.
A visible lump is definitely worrying. But the source of stress there can be urgent problems too. We need to be clear about this. What's the actual emergency situation parents need to have on their radar?
Exactly. This is why treatment is usually recommended. The emergency is what we call incarceration or strangulation. Incarceration means that piece of intestine or tissue gets trapped in the opening. It can't slide back in. And if it stays trapped, the blood supply to that trapped tissue can get squeezed off. That's strangulation. And that's really serious because the tissue, the intestine, can start to die pretty quickly.
Okay, so how would a parent know that's happening? What are the warning signs for incarceration or strangulation?
If that lump suddenly becomes hard, it feels tender when you touch it, and you can't gently push it back in like maybe you could before, that's a big red flag. Also, if the child seems to be in a lot of pain, starts vomiting, develops a fever, or is just unusually fussy or irritable, that's potentially an emergency. You need to get to the ER right away. It shifts very fast from something to watch to something critical.
That's vital information. Knowing the difference between watchful waiting and get help now. So, okay, a parent sees something, they're concerned. How does the doctor confirm it's actually an inguinal hernia, especially with a tiny patient?
It usually starts with a physical examination. The doctor will carefully feel the groin area for that lump. And since you can't exactly ask a baby to cough or bear down on command, the doctor will often observe the child during moments of natural straining, like when they cry or wiggle during an exam or diaper change. They're looking for that bulge to appear under pressure.
Makes sense. What if it's not obvious during the exam?
If there's still some question or the lump isn't present right then, they'll often order an ultrasound. It's quick, doesn't hurt, use the sound waves. It can clearly show if there's intestine or fluid caught in that area, confirming the diagnosis. Blood tests aren't usually needed unless they suspect a complication like infection, maybe with an incarceration.
Okay, diagnosis sounds pretty straightforward then. Let's talk treatment. Once it's confirmed, is surgery always the next step? What are the options?
For kids, surgery is almost always the answer. Unlike some adult hernias, these rarely go away on their own in children, and that risk of incarceration we just talked about is just too high to ignore. So there are basically two main surgical approaches we see discussed.
Okay, what's the traditional method?
The traditional way is called herniorrhaphy, or an open repair. The surgeon makes a small cut in the groin, gently pushes the tissue back where it belongs inside the abdomen, and then stitches the opening in the muscle wall closed. It's been done for a long time, it's safe, and works very well.
And the other option? The less invasive one.
Right, that's laparoscopic surgery. This uses a few tiny incisions and a camera, along with special instruments. The appeal here, especially for parents of active toddlers, is often the recovery. The research suggests laparoscopic repair can mean less pain right after surgery and often a quicker return to normal activities. Maybe just a few days of taking it easy compared to potentially longer for open repair.
Ah, so that faster recovery could make a real difference for the family's routine and the child's comfort level.
Exactly. It can really impact things like time off work for parents and just getting the little one back to feeling normal sooner.
But you mentioned surgery is almost always the answer. Are there exceptions? When might they just watch it for a bit?
Yes, there are specific situations. The clinical sources mention that observation is sometimes an option, but it's really reserved for specific cases, mainly very premature infants. If the hernia is small and easily reducible, meaning the doctor can push it back in without trouble, they might wait a short time, under very close medical watch, to see if the baby's continued development might help the opening close on its own. But that's always a carefully monitored decision.
Understood. Now, this whole process, finding a lump, hearing about surgery, anesthesia for a baby, it sounds incredibly stressful for parents. The source material talked about the emotional aspect. What does it really mean for families going through this?
Oh, it's huge. Parents often feel a mix of things. Sometimes guilt, wondering if they did something wrong, especially when they learn it's often congenital. There's also just the sheer fear of surgery and anesthesia for such a small child, and worrying about how to manage pain afterwards when your baby can't tell you exactly what hurts or how much.
Yeah, that helplessness must be tough.
Definitely. And that's why the sources stress that good clinics really focus on emotional support and clear communication. It's about explaining things simply, maybe using pictures, being really clear about the anesthesia, what recovery will look like day by day. Parents need to feel like they understand what's happening and are part of the decision-making, not just rushed into something scary.
Add support sounds crucial. Okay, one last point before we pull this together. Prevention. Is there anything parents can actually do to stop this from happening in the first place?
Well, because that main cause is often the developmental issue, that processus vaginalis not closing, it's not really something you can entirely prevent. It's just how things developed. However, families can try to minimize those pressure factors we talked about. So getting treatment for chronic coughs, managing constipation so the child isn't straining excessively, and maintaining a healthy weight can potentially reduce the strain on the abdominal wall. But it doesn't eliminate the underlying possibility if the weakness is there.
Okay, so we've covered quite a bit the basics of what it is, that developmental link, the signs like the disappearing lump, the emergency signals, the surgical options like open versus laparoscopic, and the emotional side of things. For parents who are hearing this and thinking, I need more specific guidance, or where can I find experts who handle these sensitive issues, knowing where this kind of clinical insight comes from is helpful.
Exactly. The information we've been discussing is grounded in the kind of work done at dedicated pediatric clinics. These places focus entirely on children's health, offering everything from, sick visits, acute pediatric care, to regular checkups and immunizations, which is preventive care. And they often have specialized services too, things directly relevant, like support for newborns, maybe even newborn circumcision if needed, or managing things like childhood obesity and offering lactation services, which can be so vital early on.
Right. So for our listeners, particularly those in the Atlanta area, if you're looking for that kind of expert pediatric care, or you want to explore treatment options for something like an inguinal hernia in more detail, or access services like lactation support, or find out about after-hours care, we strongly recommend checking out omegapediatrics.com. That's OMEGA pediatrics.com. They are focused on providing that expert guidance and care for families facing exactly these kinds of children's health concerns.
You know, thinking about all this leaves me with a question. When parents are faced with that choice, maybe between the traditional open surgery and the minimally invasive laparoscopic approach for their child, beyond just the immediate recovery, what are the longer-term considerations? Things like scarring, maybe future abdominal comfort, or even just the psychological impact of minimizing the trauma of a procedure in childhood. It's an interesting angle on balancing physical healing with emotional well-being down the road.
That's a really thoughtful point, something for parents to consider deeply. If today's conversation helped you get a clearer picture quickly, please do take a second to like this video, subscribe to our channel for more insights like this, and maybe share it with another parent who could use this information about this unseen culprit.
Thanks for joining us and trusting us with your time today.